Ok, boa tarde, good afternoon. Estamos aqui para começar a nossa primeira edição do Echoflix hoje e temos um convidado especial que é o professor Michael Rigby, como nós tínhamos falado, do Royal Brompton de Londres. Michael, thank you very much for being with us today, starting our Echoflix initiative. Antes mesmo do professor Rigby falar, eu queria só dizer duas palavrinhas sobre a nossa ideia do Echoflix, né? Uma coisa nova que a gente está fazendo. E o que nós estamos procurando com essa plataforma é uma maneira dinâmica e suave que a gente possa passar alguns conhecimentos de eco e discutir casos clínicos interessantes aqui com a gente. Então, a gente vai ter essa plataforma, ela vai funcionar um pouquinho semelhante, né, à plataforma do Echoflix, mas o nosso interesse principal dentro disso é o de disseminar conhecimentos, é o de promover a interação de profissionais de saúde, né? E apoiar os trabalhos que a gente tem aqui na ONG, né? No Círculo do Coração. Então, essa é a nossa plataforma e à medida que nós formos trazendo exames, necessariamente não só de eco, mas de outras imagens, nós vamos estar aqui, então, discutindo com os colegas. I'll just give words now to Professor Rigby or other colleagues that may be watching us from afar, to say thank you very much, Michael, and to say that the idea, as it says there, is that we can disseminate knowledge through our group, our teaching group, the Caduceus. We can get interaction of health professionals. Many colleagues have been joining us, which is very good. And that we can also, with this, support some of the activities of our NGO, the Heart Circle. So with that, I would like to thank also Catarina Cavalcante, our colleague who is also coordinating and is the head of the scientific part of our institution. So she is promoting also the development of our work here. And Fernando Moraes, a well-known heart surgeon here who does surgery in pediatrics, adults with congenital heart disease. And we thought it was very interesting also to have his presence to talk about the importance of the diagnosis for the surgical correction. Certo, gente? Então, Catarina e Fernando, muito obrigado pela parte clínica, pela cirurgia, a importância, né, do diagnóstico clínico para uma cirurgia adequada. E eu vou, então, passar a palavra para o Dr. Rigby, enquanto eu troco a tela e a gente começa. Mike, I'll let you say a few words before we start. It's great, really, to have you joining and helping and supporting us in this initiative. Thank you so much for being here.
It's quite exciting, I think, isn't it?
Mm-hmm. Yeah. Catarina, quer falar algo também?
Como sempre, Sandra e suas ideias. Eu acho que vai ser muito interessante essa interação entre clínicos, cirurgiões e outros profissionais de métodos de imagem. Estou apostando que a gente vai ter boas oportunidades de discussão.
Fernando?
O som, Fernando.
Oi, Sandra. Inicialmente, queria agradecer o convite, parabenizar você pela iniciativa. Isso é mais uma forma disruptiva que você tem encontrado aí para expandir o conhecimento e com o número de pessoas com o nível de conhecimento, já tem feito contribuições parecidas com essa que você está fazendo. Seguramente, esse é um empreendimento que eu não tenho dúvida que vai lograr muito sucesso, trazer muito benefício na fase final aí, que vai ser realmente o paciente, né? Particularmente no dia de hoje, as crianças com cardiopatias congênitas. E um grande prazer estar aqui com o nosso grande amigo, né, o nosso embaixador da cardiologia pediátrica aqui no Brasil, que é nosso amigo Michael Lee.
Yeah, always wonderful to have Michael around, and everyone thanking you so much for taking your time to share with us your knowledge, Michael. So perhaps what we could do would be to start showing the little video that we had sent to the colleagues, and then I'll stop and you make comments, and I will we'll go English, Portuguese for our colleagues, and Fernando and Catarina will be helping me on that. All right? So let me show the first image, and
So, should I talk?
Yes, please.
I'm going to say we selected this video clip because it's a kind of a classic example of the diagnosis. And the first thing is this is a subcostal four-chamber view. So we're looking up inferiorly through the heart. And when you see there the common AV valve leaflets, you'll see that is the inferior bridging leaflet that has multiple caudal attachments to the crest of the ventricular septum. So you just play that through. You can.
Sure.
There we are. You can see the large primum defect. And you can see that underneath the inferior bridging leaflet there, there's hardly any ventricular component, which is quite frequent. Often the ventricular component of the AVSD is more anterior. So, and here we've got the color flow Doppler, which shows not only the primum defect, but also you can see some flow across what presumably is a small secundomatral septal defect or stretched PFO. And also we can see beautifully, can't we, the normal pulmonary venous connection. So the color flow Doppler also allows us here to see left and right sided pulmonary venous drainage, which we can presume is normal. And then good. And then the next step is the subcostal left oblique short axis of the common AV valve. Remember, the common AV valve has 5 leaflets, which are difficult always to see on echo, but what you can see in this case is there's a good left mural leaflet in the left ventricle. So there's the valve half open there. But it illustrates very nicely the common AV valve, which will be inside a common atrioventricular junction, quite distinct from the normal heart, which has separate right and left AV junctions with the tricuspid and mitral valve. So you can't call this tricuspid or mitral, it's a common AV valve. I think there may be one other 4-chamber shot, is there? Or maybe there's not, is there? Yeah. So this is an apical 4-chamber shot. And this is the one which shows the superior bridging leaflet, which has connections in both left and right ventricle. And there you can see the ventricular component underneath the superior bridging leaflet. The interesting thing about this heart is that you can't really see any significant left or right atrioventricular valve regurgitation or decided. Or you can see some regurgitation there, going into the right atrium. The regurgitation is often between the bridging leaflets. It's almost like ventricular atrial shunting. So this is we're not here looking at the left or right ventricular outflow tracts, which in this case were widely open, but it's always worth checking because occasionally you get right or left ventricular outflow tract obstruction in a complete AVSD. And
Michael, I'll just say some of these things in Portuguese, perhaps in others, I don't know, perhaps I should interrupt you and say it from the beginning.
Carry on. Sorry.
Yeah. Anyway, é importante, gente, que o Dr. Rigby dizendo que um exemplo bem típico, né, do defeito do septo atrioventricular, no início ele falou sobre a grande CIA ostium primo e que a gente via também aquele fluxo com o que provavelmente representa uma pequena CIA ostium secundo, né? Ficou bem claro quando a gente viu aquela parte aqui do fluxo, né, onde a gente vê a passagem por aqui e a passagem do ostium primo. Ele falou no início da importância da gente ver no subcostal o folheto ponte posterior, né, que a gente vê aqui, o posterior bridging leaflet, que fica visto na parte do subcostal, e depois falou das ligações aqui no topo do septo, não é isso? Que a gente tem. Michael, one of the questions that you made in your group here was precisely what Rastelli type it was. Remember that we had this, I think, in here at some point, and many of the people that looked at that and answered that said that that was one of the most difficult questions to answer. Perhaps you could say something about this, about the Rastelli types on echoes, how we identify. Gente, eu perguntei a ele como ele fala dos tipos do Rastelli na ecocardiografia.
So, you're asking me to comment on the Rastelli type. I think to the surgeon, the Rastelli type is not so important. But basically, in Rastelli type A, between the superior bridging leaflet and the right anterior leaflet in the right ventricle, the cords go near to the top of the ventricular septum. In the Rastelli type B, they go to the base of the ventricular septum. And in Rastelli type C, they go to the free wall of the right ventricle. So if you just let this one play, let's see what we think. And you would see it in this view, the apical four-chamber view.
Só mostrando aqui, e o que ele disse, né, que no Rastelli A, normalmente, entre o anterior e o posterior, os folhetos pontes, as cordas vão para o topo do septo, no B, elas vão para a base do septo, e no C, elas vão para os lados, vão para as pontas. Foi a explicação. E aí ele diz, agora vamos olhar e ver o que a gente acha em relação ao Rastelli. Né? Eu comentei com ele que várias pessoas perguntaram sobre o tipo de Rastelli. Catarina, talvez você queira comentar também aqui sobre...
Eu só gostaria de acrescentar a visão da CIV no corte subcostal, né, que a gente mal vê a CIV no corte subcostal, a diferença para o corte apical 4 câmaras, né, que a gente vê nitidamente a CIV aí, vê o tamanho da CIV. Ele também falou do refluxo do componente direito da válvula V comum, que tem um refluxo leve para o átrio direito. Mas, assim, importante... e também o eixo curto da válvula V, né? Que a gente pode determinar alguns componentes da válvula V comum. Mas, sobretudo, a diferença do tamanho da CIV entre o corte subcostal e o corte apical. Aí a gente está vendo o folheto ponte anterior nesse apical e no subcostal, só repetindo, a gente vê o folheto ponte posterior ou inferior.
Isso, perfeito. Let me ask Fernando something about this now, which is for the surgeon, the repair of Rastelli A, Rastelli B, Rastelli C. Does that make much difference for you? Are there cases which are necessarily easier or more difficult? Fernando, tem muita diferença?
Yes, Sandra. Thank you. And I'd like to disagree a little bit with Michael, because I think it's important at this stage to classify very well not only the type of Rastelli and also the chambers, the right and left ventricle chambers. The size of them are very important in the prognostic aspect and the indication aspect. I think we will discuss a little bit later about this subject, but for us, I think it's important, Michael, to can I keep it talking in English, Sandra, or you prefer?
Tranquilo, e a gente vai misturar, tá? Tranquilo. Depois a gente passa um pouquinho para o português, né? Você está dizendo que para o cirurgião é muito importante a definição não apenas do tipo do Rastelli, como também das dimensões de câmaras, né? Se há uma preponderância de câmaras direitas ou esquerdas, não é isso?
Yeah. I think it's important to make the correct diagnosis, and we be sure we not open the heart and be surprised with some cords that are crossing the septum. To correct, in reality, we can fix the bovine pericardium, the patch, a little bit in the opposite side of the ventricle. avoiding to fix the cords and get problems related to regurgitation after the operation. I think it's very well. I mean, it's not so difficult to fix the VSD. Eu acho que não é tão complicado nós consertarmos, nós repararmos, nós fecharmos a comunicação interventricular, mas eu acho que é importante a gente ter sempre esse diagnóstico para não ser pego de surpresa, é o que eu queria dizer, durante a cirurgia. E um outro aspecto é relacionado também ao tamanho das cavidades ventriculares, né? Eu acho que tem uma implicação nos cuidados do pós-operatório e alguns outros aspectos que a gente deve ter em mente em crianças com essa cardiopatia que desenvolvem precocemente hipertensão arterial pulmonar. Talvez a gente vá discutir um pouco a respeito desse assunto mais adiante. So, Michael, just to translate a little bit what I said, I think we can fix the VSD with the patch, despite of the type of the classification of the AV canal, Rastelli A, B, or C, and I just point out the importance of defining if it's a very well balanced heart, and also the importance of making the diagnosis very early in life because of the pulmonary hypertension that these children develop very early in the infancy.
There is a question here, which I think would be nice to show. Eu coloco ela em inglês para ele e a gente vê, por conta dessas questões da hipertensão pulmonar e de tudo isso, a correção cirúrgica, perguntar a opinião dele. This is for you, Michael. Do you tend to correct them very early, neonatal period, between 3 and 6 months? Or what would be the...
In reality, they end up being operated on between the ages of probably 10 weeks and 4 months, you know.
Mm-hmm.
Sometimes if they're putting on a bit of weight, our surgical team like to wait a bit. Maybe it's, you know, if you can get the baby up to 4 kilograms, it's an easier operation than at 2.8 kilograms, isn't it, Fernando? So maybe a little bit as big as possible, but not too old before they've developed pulmonary vascular disease, yeah.
Eu acho que você mais ou menos concorda com isso, né, Fernando? Esse período na faixa etária.
Absolutely, I agree very well.
Operar nessa fase, né, gente? Nos primeiros 6 meses, antes do desenvolvimento da hipertensão pulmonar, mas não tão cedinho quanto o período, não no período neonatal. E essa pergunta, and this one, Michael, do you think Downs have a different prognosis, better or worse, or in your experience now in the UK, it's about the same?
The other thing I was going to say about this case was if you look at that image now, that frozen image, you'll notice that the inlet to the right ventricle is quite a lot bigger than the inlet to the left ventricle. Just point out the inlet to the left ventricle. So the left ventricle is quite a lot smaller, and it's partly because of that very prominent left-sided atrioventricular sulcus. Yeah. So, although this on the surface looks like a good anatomy AVSD, that inlet is a bit small, isn't it? So you just have slight concerns that you may end up with a small left AV valve or something like that. It's never, this is never an easy operation, Fernando, is it?
Yes, Michael, that's a good point you raised here, because one of the complications that we have if we are not aware, one of the complications of closing the VSD is making the outflow, the left ventricle outflow tract a little bit smaller. If you have a case like this, if it is already a little bit narrow, We have to be aware of that. What do you think about that?
In terms, yeah, well, I agree with you. I think yes. I mean, just generally, it's always very important. Everybody knows how difficult this operation can be for the surgeons. Leaflet tissue can be quite abnormal once you get in there. This looks on the surface quite a reasonable case, but at the time of surgery, which was shortly after I made that video, the surgeon did find the left ventricular inlet was a bit small, ended up with some regurgitation and what have you. So, it's never a walk in the park, as we say.
Good. Katarina, would you like to say something about this? I'm trying to write down some of the things that you say in Portuguese because it makes it easier for us to be following. So I'm trying to.
Eu concordo com tudo que foi dito, que é uma cirurgia muito difícil. Eu acho que é nessas horas que os cirurgiões cardíacos pensam que são quase deuses mesmo, porque no coração pequeno, com tecido valvar que pode variar muito, né, como o Michael disse, transformar aquela válvula V única em 2 orifícios, fechar os defeitos, e é uma cirurgia plástica, no meu entender, né? Eles estão fazendo uma cirurgia plástica dentro do coração, que é realmente muito difícil, e não é incomum que a gente termine com, às vezes, o paciente com alguma obstrução na via de entrada do ventrículo esquerdo, ou, ao contrário, regurgitação da válvula V esquerda. Então, realmente, eu tenho o maior respeito por quem faz esse tipo de cirurgia.
I agree. It's a bit of an art to transform that one single valve into 2 good working, good functioning valves. So, and it's very common that we see that one valve may end up with some insufficiency, the other valve may end up with some regurgitation. Fernando, is there like an option for the surgeon when you're doing it that you may how do I say this? For instance, you may try to do as much as you can to let the left AV valve, which will be working under higher pressure and all this, to work better. If you have to decide on how to work with that tissue, is this something that the surgeon can choose to do, or is it very dependent on the original, the way that the original valve is? Deixa eu só dizer esse em português, porque foi comprido. Eu perguntei se o cirurgião pode, de alguma forma, tentar fazer com que uma das válvulas fique melhor, se ele não conseguir fazer as duas, e fazer com que a esquerda seja preferencial, já que trabalha com pressão alta, ou se isso é completamente dependente da anatomia inicial daquela válvula. Uma curiosidade que eu tenho.
Well, Fernando will tell you that you can position your patch to close the ventricular component as such that you provide a little bit more of the bridging leaflets for the valve in the left ventricle. So you can alter the position of your patch to optimize the left ventricular AV valve. That's true, isn't it, Fernando?
It is. That's a good, and I think it's the most important point I take in these operations is to look after and to try to make the left AV valve working perfect, because regarding the prognostic and the prognostic aspects in these children, and also in the immediate postoperative care, the importance of having the left AV valve working properly is fundamental. It's very important. And taking your point, Sandra and Michael, I usually try to keep more tissue bridge leaflets to work and to correct the left AV valve than the right side. So I usually, when I need to divide tissues, the part of the leaflets, I usually keep more tissue to the left AV valve, because it will be more easy to correct and to let this valve working properly. What I mean when I say working properly, open, making the inlet of the left ventricle very wide, and when we test the valve, make sure that will be closing with good area of coaptation, because it will also have just, for example, 1 millimeter of coaptation area. It means that in the near future, it can, when the heart dilates a little bit, or when the child gets older, the coaptation may be working not properly, and we start having some mitral regurgitation. So I think it's a very important point to be aware. To take during the operations is to give some preference to correct the left AV valve and make sure that will be working well.
Well, I think those are very, very important issues for the surgeons, and I think for the echocardiographers, I think it's also a key to be able to show this anatomy well. So in this case, I suppose, for those of you who asked, I think it's the Rastelli B. Is that correct, Michael?
I think so, yes. Although in this particular case, the more I look at it, the more difficult it is to decide. But I think it's Rastelli type B, going towards the apex, the base of the septum,
Yeah, yes. In some areas you see some going to the top, but I think Rastelli B.
But it's not so easy to tell. The other thing to say is that the so-called Rastelli type C tends to occur more frequently. For example, if you have tetralogy of Fallot with an ABSD. So when the ventricular component is bigger, would you say this is true, Fernando?
Yes, it is. Fortunately, Michael, it's not a very common association.
No.
Fallot and the AV canal. So, but in the correction is always a challenge. Not the correction, the surgery, but also the better time to operate the children. What kind of operation we should do in these operations? It's a very complex, and I have to say that I do not have a very big experience doing total corrections at the first stage in this group of patients. I also would like to hear a little bit about your experience. If you want to translate this, Sandra, now.
Fernando, vou lhe pedir desculpas, eu estou escrevendo, traduzindo, estou tentando fazer um bocado de coisa. Eu não foquei no final, quando você disse a opinião.
O que foi comentado aqui do Michael é a associação do Rastelli tipo C e sua relação com uma outra cardiopatia congênita, a tetralogia que falou, que parece ser mais frequente. E eu comentei que realmente é uma associação que, felizmente, ocorre com muito pouca frequência. A tetralogia falou com defeito do septo AV. E um outro dilema é que cirurgia fazer, em que momento fazer a cirurgia. Se a correção está total, se uma cirurgia paliativa inicialmente. São um conjunto de associações que requer um ecocardiograma muito bem feito e uma decisão que deve ocorrer de forma multidisciplinar, entre a clínica, a cardiologia, a hemodinâmica. Eu acho que é um capítulo à parte dentro das cardiopatias congênitas complexas como essas aqui.
Perfeito. Ótimo, entendi. Michael, do you go for total correction in AVSD with tetralogy, or would you palliate first? Or
well, if possible, obviously, if it's a balanced situation with pulmonary stenosis, you may be able to wait till the age of 6 months or 8 months before you do the repair, which I think makes it slightly easier for the surgeon. But I think, AVSD antitralogy is quite a difficult operation, isn't it, Fernando? It's not so. You want I think if you can get the child up to 6 or 7 kilograms, it makes it more likely you'll get a good result from the surgery.
I agree, Michael. I think, if you could operate these children, near, as you said, about 10 kilograms, it would be, I think.
If the baby's very, very blue early on, then we'd probably do a Blalock shunt, or we might even stent the right ventricular outflow tract. We do that sometimes instead of putting in a shunt. But just to buy a few weeks and months.
I agree. I think so. I have
a question. I have a echo question to Dr. Rigby. Michael, what's the best view to make the diagnosis of the type, Rastelli type? What's the best view you find?
It needs to be the anterior view that shows the superior bridging leaflet. So it needs to be an apical 4-chamber view or parasternal 4-chamber view showing the superior bridging leaflet. And then you'll see the superior bridging leaflet somewhere in the right ventricle, just on the right ventricular side of the septum, forming a commissure with the right anterior leaflet, and it's where the cords go down from that commissure between the superior bridging leaflet and the right anterior leaflet.
Okay, Sandra, can you show the image, where you see the AV valve in a short axis? I'd like to ask Michael if he could say in this view what parts of what leaflets you can. Please. Yes, it's another thing that I find difficult.
So stay there. So at about 11 o'clock on that common junction, we go to 11 o'clock.
Yes.
And then go round to the aortic valve. That's the superior bridging leaflet. Just go round a bit more. No, the other way, clockwise. So that's the superior bridging leaflet there. And then directly at the bottom at around about kind of 6 o'clock or 5 o'clock will be the inferior bridging leaflet.
All right.
And then round about 10 o'clock is the anterior leaflet. So you look at 10 o'clock on that circle. And then if you look at about 7 or 8 o'clock is there's the right mural leaflet.
Okay.
Then if you go to 3 o'clock,
Sorry. I touched it without. Let me open it again. Okay.
3 o'clock is the left mural leaflet.
Okay, thank you. Your images are very beautiful, Mike.
Yeah,
very nice.
These are lovely, aren't they? Actually, beautiful. And in a way, we've got 3 clips here, but 3 or 4 clips. They almost provide all the information.
Yes.
Sure. Very well documented. Michael, one of our colleagues who is watching here has asked. She has a patient, and this is from a patient that she's seeing. She's a 3-month-old baby, which is low weight, is Down syndrome, has a complete AVSD.
So how old?
3 months. 3 months.
3 months, yeah.
3 months, low weight, Down syndrome with AV septal defect complete, and in treatment for leukemia, had treatment for leukemia in the neonatal period. She says that clinically the child is unwell, and the question is, should she go for total correction or do PA bending? 3 months down AVSD and previous treatment for leukemia.
one of the problems with banding the pulmonary artery in AVSD is it's not the perfect operation. If you've got AV valve regurgitation, it doesn't prevent that, it may make it worse. And also, it doesn't reduce the shunting at atrial level. So you can still do a good pulmonary artery band and still have a high pulmonary blood flow. So it can work, but if you just go in and band the pulmonary artery, it's not necessarily a perfect solution. Don't you agree, Fernando?
Yes, Michael, I agree. I think we have to be the correct echo diagnosis, saying that DSVT is the diagnosis. We need to know very well what's happening with the AV valves.
Yeah.
If it is, insufficient or not, because as you said, to make it worse. And the other point is, why is this child on low weight? Is it because of heart failure or not? We have to deal. To know. Why is she? The child on low weight, because of the heart or because of the other disease? Well, people should know
What is the baby's weight now?
Patrícia, pode colocar o peso. She's just saying here that she agrees that she generally will not indicate PA bending for situations, but this child is in low birth weight due to the heart failure, and because of everything that's happening, they were considering doing bending. That's not our first.
If there's not severe AV valve regurgitation, you could try it. I always think the important thing is, if you've banded the pulmonary artery, band it tight enough, if the surgeon banded it tight enough, and get the baby off the ventilator almost immediately if you can, because once they're stuck on a ventilator, and don't give oxygen post-operative, because that makes the pulmonary blood flow higher. Little things like that,
Yeah.
Não usar O2 no pós-operatório, né? Importante aqui essa colocação que foi feita. 2,300, 2.3 kilograms for a 3 months old baby. So pretty
difficult problem. Maybe try banding the pulmonary artery. It's difficult.
Agree.
Ele concorda, viu, né, Patrícia, de tentar talvez por isso. We have another question that's coming from a good friend of ours.
I've got about 10% battery left on my phone, so I've got another 2 or 3.
Don't worry, we have 5 minutes. Well, perhaps you have to leave before, because we're going to stop on time. But anyway, this is Luciana from the United States, I believe. José Pedro, yeah, Luciana. And she has asked, you have seen, Michael, associated of AV septal defect and parachute valve in the left side.
Yeah.
So
AVSD with a parachute deformity tends to occur when there is absence of the left mural leaflet. So you end up with a kind of a bi-leaflet valve in the left ventricle instead of having the usual 3 leaflets. So absence of the left mural leaflet, so only the superior and inferior bridging leaflets. And then that is often associated with the parachute deformity and a relatively small size of the left AV valve. So when you go for a repair, you may end up with left AV valve stenosis. Difficult problem. I think if you've got a parachute valve in a parachute left ventricular leaflets, as it were, in the left ventricle, it certainly makes the repair more hazardous.
Fernando, would you like to comment on this? I don't.
I've never seen, and I've never seen a case like this, and so it's very difficult to make a comment in such a complex case. But as usual, parachute, mitral valves, it's a challenge to correct per se. I can imagine having this association to be more complex. So.
Yeah, I think Fernando, some of those cases where you've got left ventricular hypoplasia, that that the cardiologists are not going to refer for surgery, at least to do a biventricular repair. Some of those will have a parachute deformity, so it's a kind of it selects itself out as being a group that sometimes is inoperable and therefore doesn't come to the table for a complete repair.
I see.
So I think you're protected by your cardiologist from some of those cases, you know.
Yeah.
I've never seen a case of this.
Luciana.
I'll show you a case next time if I can find it.
Okay.
Very good. And Luciana says that she's just seen one case last month, which is great. Let me tell you one thing. I did not expect this session would go anyway different. I knew we had a most beautiful case presentation, top colleagues to comment, and I knew this would be of great interest. I must thank everyone that took part in this. We are on time, right? In the very few last minutes. I'd like to thank very much Katarina, Fernando, and you who have been watching us and asking questions and all this. I think some of the questions I won't be able to take anymore, but we'll be able to discuss them, and perhaps online we can do this. If you just go onto that channel on YouTube and leave your questions, we can continue to interact with Michael, and he's already promised that will show us one case, which will be even more complex for one of the next few sessions. But now we'll have to be finishing very soon. So I'll just send for Michael to any finishing remarks. Thank you again very much, Michael, for being with us.
Thank you very much. Always a thrill. Always a thrill even to feel I'm in Brazil, even if I'm not there, you know.
Yes, that's the way. We'll have to take you to do some of the sessions right here with us, sitting in these rooms. Katarina?
It was a pleasure, great pleasure. I want to thank you, Sandra, for promoting this. Thank you, Michael, very much to be with us in this excellent discussion. And thank you, Fernando, as well, for being with us. So hope to see you next time. Bye-bye.
See you next time. Bye-bye, everyone.
Thank you.
Bye-bye.
Bye-bye.
Fernando, bye-bye as well.
Bye.
Thank you.
Bye-bye. Thank you.